Okay. Okay. 3 days after undergoing emergency partial gastrectomy, uh, 3 days under 3 days after undergoing emergency partial gastrectomy for upper gastrointestinal hemorrhage, a 72-year-old man has increasing abdominal pain. His postoperative course has been uncomplicated. He has hypertension treated with lisinopril and type 2 diabetes mellitus treated with glipizide. He underwent coronary angioplasty with stent placement 2 years ago. His current medications are patient control morphine and subcutaneous unfractionized heparin. He is anxious and diaphoretic. His temperature is 37.2 degrees Celsius. Pulse is 110 per minute, respiration 20 per minute, blood pressure 145 by 90 millimeter of mercury. Examination of the abdomen shows upper midline incision without signs of infection. The remainder of the examination shows no abnormality. His hematocrit is 32%, leukocyte count is 8,000. In addition to administering morphine, which of the following is the most appropriate next step in the management?
Ready?
1 second. Okay,
So this
ready?
is, yeah. So it's 12 lead ECG, perioperative cardiovascular complications, referred to as major adverse cardiovascular and cerebrovascular events, are significant cause of mortality in non-cardiac um, surgical cases. Anesthesia and surgery place the body under tremendous physiologic stress, which can lead to MI, myocardial ischemia, infarction, and potential cardiac death. This patient has several cardiac risk factors, including history of coronary artery disease, um, and currently presents with abdominal pain, anxiety, diaphoresis, tachycardia. 12-lead ECG and serum troponin levels should be obtained immediately to evaluate for um, ACS. The risk of MACE occurring can be determined by the use of validated cardiac risk assessment tools such as the revised cardiac I don't know what it is. Surgical. In general, the patient functional status prior to surgery is often the best indicator of perioperative cardiovascular risk. It is not CNT. CT scan. CT scan of the abdomen may be considered given the patient abdominal pain, recent surgery, has surgical site infections, and dehiscence and potential complications. However, the symptoms are also indicative of ACS, and a 12-lead ECG should be performed. Operendoscopy is not likely to be useful in the immediate diagnostic workup of this patient. It may be needed if the patient presents with recurrent bleeding or complication involving the gastric pouch. However, ECG lab studies and imaging sure it should be performed first. Okay.
Next.
Next.
A 62-year-old woman comes to the physician for a routine health maintenance examination. She does not smoke and only drink socially. A systolic ejection murmur is best heard over the second intercostal space with transmission to the carotid arteries. An ECG shows normal sinus rhythm and a pattern of left ventricular hypertrophy with strain. Which of the following manifestation would indicate the need for aortic valve replacement. Ready?
No.
Okay.
Okay, ready.
Okay. This
You know what?
interruption, sorry, disruption. Okay, let's
Anyway,
see the answer.
it's a angina and syncope. Aortic stenosis is a common disorder of aortic valve that results in from calcification. Calcification of aortic valve is a pathologic consequence of mechanical stresses on heart valves and results from repetitive microtrauma from the opening and closing of the valve leaflets with associated inflammation. While many patients may be asymptomatic, those with severe aortic stenosis may complain of fatigue, shortness of breath, cough, diminished exercise tolerance, angina, syncope with excesses due to the chronic increase after load from fixed obstruction of the valve, left ventricular hypertrophy, and diastolic dysfunction can occur. If untreated, complications of aortic stenosis include heart failure, secondary pulmonary hypertension, sudden cardiac death, angina, and syncope result from an inadequate end organ perfusion of the myocardial membrane. The presence of these symptoms in the setting of aortic stenosis is an indication for the aortic valve replacement. Okay. Next.
Yes. A 77-year-old man, a 77-year-old man comes to the emergency department 5 hours after he was awakened by severe pain in his severe pain in his left leg. He reports that his left foot feels numb and cannot move his foot and toes. He has 4 year history of stable claudication of both calves and a 40-year history of hypercholesterolemia and a 15-year history of diabetes mellitus. He was recently diagnosed with atrial fibrillation. He was recently He was recently diagnosed with atrial fibrillation. Medication include aspirin and digoxin daily. He is in mild distress. His pulse is 84 per minute and irregular blood pressure is 145 by 85. The left lower extremity is pale and cool below the knee. Femoral pulse is 1 plus on the right and absent on the left. Which of the following is the most likely diagnosis?
Ready?
1 second. Okay.
It is left femoral artery embolism. Peripheral artery disease refers to abnormally diminished flow of blood to the extremity secondary to atherosclerotic plaque. This most commonly affects the lower extremity. Risk factors: diabetes, age, tobacco, hypertension, dyslipidemia. Patients typically present with claudication caused by insufficient blood flow to the muscles during exercise. As the flow of blood becomes progressively diminished with worsening atherosclerosis, tissue perfusion may become inadequate to meet metabolic demand. In acute cases of liver ischemia, patients generally present with pain, pallor, paresthesia, loss of temperature sensation, paralysis, postlessness. Acute deep ischemia can complicate the state of already diminished vascular supply in PAD, such as when an existing plaque ruptures in situ leading to thrombotic acute ischemia, or when an embolic source abruptly includes an already narrow vessel, such as AFib. AFib, when suboptimally anticoagulated, as in this case, the patient risk factors may lead initiation of blood thinner beyond aspirin to prevent left atrial thrombosis, and risk of embolism. What is he taking? Only aspirin. Okay. Can result in distal embolization of thrombi. This leads to stroke, acute ischemia, mesenteric renal ischemia, ACS, or other phenomena of end organ hypoperfusion, depending on the location. Acute management of thromboembolism includes anticoagulation, analgesic reperfusion like vascular bypass, endovascular, or open thrombectomy. Next.
A 67-year-old woman developed swelling of her left leg 3 days after raw and Y choledochojejunostomy for an obstructive cancer of the head of the pancreas. Venous Doppler ultrasonogram is positive. Which of the following is the most appropriate next step in the management? You ready?
Yeah, I guess. So is therapy with heparin. Leg swelling following. Leg swelling following recent surgery and non-malignancy may provoke DVT. DVT thrombus within the deep end of the body, generally the leg, is generally provoked by features of visco triad, which is venous endothelia and precoagulability. In this case, these factors such as surgery, malignancy, and prolonged immobilization likely contributed to the development of DVT. While distinction of unprovoked and unprovoked DVT matters, in deciding the long-term anticoagulation in the immediate setting, the management is the same regardless of the reason. An anticoagulant is the appropriate next best step. Recent surgery may be considered a relative contraindication to anticoagulation, and careful assessment of bleeding risk should be considered. Clinical calculus. Anticoagulation with heparin may be preferred for selected patients, particularly those with a history of recent surgery or malignancy due to greater ease of reversal of heparin compared to other antigens. It's not Z. Intravenous streptokinase therapy is a thrombolytic agent that may be used in extensive or proximal DVT or venous thromboembolism. Patients with uncomplicated DVT do not usually require thrombolysis. Additionally, high risk of bleeding um, is a contraindication to administration of thrombolytics. Okay.
Next. 2 hours after admission to the hospital for 2 hours after admission to the hospital for injuries sustained in a motor vehicle collision, a 77-year-old woman has the onset of tachycardia. She was the restrained driver of a vehicle that struck a tree head on. She sustained bilateral anterior fracture of the fifth. She sustained bilateral anterior fracture of the fifth and sixth rib. On admission, ECG showed occasional premature atrial contraction, and 1 liter lactated ringer solution was administered. Vital signs on admission and vital signs on admission and now are 2 hours ago is 37, now 37.4 degrees Celsius, pulse 86, now 100 per minute and irregular. Respiration 20 and 24, blood pressure 100 by 60, 110 by 60. Examination shows no jugular venous distension or pulses paradoxus posterior. Crackles are hard over the lower quarter of the lung bilaterally. Hematocrit 43%. Which of the following is the most likely cause of the cardiovascular finding?
Ready?
1 minute, please.
Yes.
Okay, ready.
With blunt cardiac injury. Blunt cardiac injury is the most likely diagnosis in this patient who recently sustained a car accident injuries and now has evidence of irregular cardiac rhythm. Blunt BCI, blunt cardiac injury, is most often seen in the setting of car accidents, and the incident is higher in those who sustain blunt trauma directly to the precord and suffer rapid deceleration. BCI can result in a wide range of cardiac injuries from mild to life-threatening. Um, okay, arrhythmias following BCI occur in approximately 5% of patients, and rhythm abnormality range from premature ventricular contractions to ventricular tachycardia and ventricular fibrillation. In most cases, in most instances, the arrhythmias are mild and non life threatening, although all patients should be admitted for cardiac monitoring. Okay. More severe complications of BCI include ventricular rupture leading to pericardial tamponade, valvular rupture, and MI, secondary to coronary artery dissection and thrombosis. Patients who suffer catastrophic injuries typically do not survive transport to the ED. Specific cardiac abnormalities, including cardiac tamponade and valvular pathology, can usually be diagnosed with echo and other clinical features such as hypotension, pulsus paradoxus, and JVT. No cardiomyopathy. What was I? Yeah, I guess cardiomyopathy. Broad term that refers to dysfunction of the cardiac muscle that may arise from numerous causes. Several varieties of cardiomyopathy include dilated blah, blah, blah. Patients present with uh, myocardial dysfunction, which may or may not be associated with arrhythmia. Okay, next.
A 37-year-old man comes to the physician with his wife because of uh, 10 10-week history of severe shortness of breath after walking 1 block and swelling of his legs. 10-week history of severe shortness of breath after walking 1 block and swelling of his legs. His wife says that he has snored for many years, and during the past 6 months, he has had many episodes every night in which he stops breathing for 15 seconds, suddenly wakes up. He has had constant daytime fatigue for the past 3 months. He has type 2 diabetes, hypertension. Current medication include insulin, AC inhibitor. He appears cyanotic and in mild respiratory distress. Weight He is 173 centimeter tall, weight is 145 kg, very BMI is high, blood pressure 144/80, hypertension. Examination showed decreased air movement in the lung base, scattered bronchi are hard, heart sounds are distant. Examination of the lower extremity shows brownie induration 3 centimeter granulation ulcer. 3 centimeter granulation ulcer above the medial malleoli. There is 3 plus pitting edema to the mandible bilaterally arterial bloodless. On the room air show PaCO2 is 50, PCO2 is 50, PO2 is 52. If this is not treated for the current findings, he will be increased risk of what? Is it OSA, isn't it?
Oh, yeah,
So OSA causes pulmonary hypertension. No, not such option.
ready?
Yes.
Call pulmonale. If this patient remains untreated for OSA, he's at risk of developing cor pulmonale. OSA is characterized by intermittent obstruction of the upper airway, leading to hypoxia apnea, history of snoring followed by periods of apnea in association with daytime somnolence and morning headache is common. Severity of OSA is determined using the apnea hypopnea index, and treatment of moderate to severe OSA includes the use of CPAP at night. The pressure supplied by CPAP keep the upper airway open, thereby preventing blah, blah, blah. Severe untreated OSA can lead to a variety of complications, including pulmonary hypertension. As the pulmonary circulation is usually a low pressure system, the right ventricle is not equipped to pump against such a high pressures. Thus, pulmonary hypertension causes secondary right ventricular dysfunction, referred to as cor-pulmonale. Cor-pulmonale manifests in finding as right axis deviation and right ventricular hypertrophy, and chest X-ray with peripheral edema hepatomegaly. The enlarged right ventricle is associated with precordial even on examination and pronounced S2, given the increased pressure on the pulmonary system impacting the closure dynamics of the pulmonic valve. This patient has evidence of right ventricular dysfunction and should be treated with CPAP at night to prevent chronic hypoxia, pulmonary vasoconstriction, and irreversible right ventricular remodeling and failure. Next.
Okay. A 62-year-old a 62-year-old man is brought to the emergency department 3 hours after the onset of shortness of breath. 1 week ago, he was discharged from the hospital after undergoing partial colectomy for a diverticular abscess. His postoperative course has been uncomplicated. On arrival, he is in mild respiratory distress. His temperature is 37 pulse, 110 per minute, respiration 22 per minute. Blood pressure 140/98 millimeter of mercury. The lungs are clear to auscultation. Abdominal examination shows well healing incision with no erythema or tenderness. Pulse oximetry on room air shows oxygen saturation 89%. Oxygen is administered via nasal cannula. His symptoms resolve. Lab findings are pending extra chest abnormality. ECG shows sinus tachycardia. Which of the following is the next step in the management?
What does he have? Hmm. Ready?
Yes.
It has P. Usually they say P comes with chest pain, but not lately. It's like all the P they don't have chest pain.
Yes.
Anyway, yeah, it's like most of the questions I find about PA, there's no chest pain. Okay, heparin therapy. This patient presentation is concerning for acute PA, and heparin therapy should be initiated immediately. I thought heparin was only for like uh, art, like a clot, like arterial clot, like in the arteries, but it's also used for DVT.
Yes.
Huh. Okay. Heparin should be initiated immediately. PE can be difficult to diagnose. It's often present with non-specific and varied symptoms. Several validated clinical decision-making aids are used, such as the Wells criterion. A patient presenting with acute dyspnea, the presence of tachycardia, history of recent surgery within the past month, and lack of a clear alternative diagnosis for symptom place him at risk for acute P and his yeah. The worst criteria also include clinical evidence of a current DVT, prior history of DVT and or PE, hemoptysis, and presence of malignancy within 6 months. He has malignancy novelly. Other symptoms and signs associated with pain include paralytic chest pain, tachypnea, and hypoxemia. Sorry. Okay. Next.
Next. 1 hour after undergoing a colon resection for sigmoid carcinoma, a 57-year-old woman is tachypneic and agitated in the recovery room. She was extubated in the operative room and is breathing 30% of oxygen by nasal cannula. She is 178 centimeter, 5 feet 10-inch tall, weight is 140 kg, BMI is 44 kg per meter square, pulse is 120 per minute, respiration 40 per minute, blood pressure 135 by 90 millimeter of mercury, breath sounds are shallow and symmetrical, heart sounds are normal, ABG analysis shows pH 7.25, PCO2 high, oxygen slightly low. Which of the following is the most appropriate next step? Acidosis. Respiratory acidosis. It is respiratory acidosis, isn't it?
Yes.
So we'll do metabolic alkalosis. What will we do?
That's what it is.
Blood pressure is good, so no fluid. She has no. There is no pain. Why we will give naloxone? Okay. So
Hmm. Between heparin or intubation.
you are
But if
thinking P
heparin is,
again.
I'm thinking PE, PE wouldn't be, it will be respiratory alkalosis, not acidosis. Oh no, right?
P can happen because he has the history of surgery. 1 hour after.
Okay, fine. Let's go with PE. And between that and intubation. Anyway, let's see.
Patient
So
is
a
hemodynamically stable. Should we do intubation?
yes is intubation. ABG, yeah, yeah, because oxygen is low also.
Low.
RBG to
Normal
reduce.
oxygen value is 80 to 100, isn't it?
Let me see. It's
Normal PO2.
75 to 105. Yeah, I guess 80 to 100.
So
75 to
not
1.
that low. Okay.
ABG indicates the patient is experiencing hypoxemic and hypercapnia, respiratory failure with clear evidence of respiratory distress. The most appropriate intubation mechanical ventilation for respiratory support, regardless of the cause of respiratory failure. And this patient requires immediate management of an acute life threat. Perioperative pulmonary complications are a major cause of mortality in surgical patients. Thoracic abdominal surgery reduces vital capacity and functional residual capacity significantly due to diaphragm dysfunction, splinting, and postoperative pain. Other risk factors for perioperative pulmonary complication include age, obesity, OSA or blood, COPD, pulmonary valve, general. It is not E, that is E. Heparin therapy will be indicated if the cause of the patient respiratory failure was PE or ACS, which are both complications to consider in order. However, the current management priority is respiratory support with intubation, and the history is more suggestive of perioperative hypoventilation as the cause of patient symptoms. Okay.
So in here the important catch is what? Respiratory acidosis is very low pH. That's why intubation is the thing.
I don't think the pH is, I think it's, yeah, I guess the low pH and the low oxygen.
These things are very confusing. Okay, let's see.
I guess getting complete. I think surgery will be one of my hard topics. Yeah. So anyway,
O-
next.
Okay. A 42-year-old man comes to the office. 40-year-old man comes to the office for examination prior to undergoing gastric bypass. He reports 2 months history of shortness of breath after walking less than 1.5 block. He has hypertension treated with hydrochlorothiazide. He is 180 centimeter tall. Weight is 171 kg. BMI is 52 kg per meter square. His pulse is 84 per minute. Respiration is 14 per minute. Um, Blood pressure is 132 by 80 millimeter of mercury. Pulse oximetry on room air shows oxygen saturation 96%. Decreased breath sounds are heard bilaterally. Decreased heart sounds are heard. ABG shows analysis of the normal room air shows pH 7.31. PCO2 is high and PO2 is low. Which of the following is the most likely cause of this patient's condition?
It's a lot of pulmonary in this surgery. Next. Sorry, ready?
Yes.
decreased ventilation. Damn it. Hyperventilation can be identified. Wait, wait, from here. Hyperventilation can be identified by decreased oxygen, increased CO2, and normal AA gradient on arterial blood vessel. Okay. In this case, the pH indicates a malacidemia, PCO2 shows hypercapnia, and oxygen is in the lower range. The A gradient can be estimated as a function of atmospheric pressure, FiO2, PO2, and adjusting for normal increase in A gradient associated with age. The patient A gradient falls within an expected range. This suggests that the cause of his hypercapnic respiratory failure is secondary to decreased ventilation, which aligns with his history of obesity and auscultation of decreased bed sound bilaterally. To determine the acuity of his respiratory acidosis, an estimate can be made comparing the amount of decrease in his pH with the associated increase in PCO2. For acute respiratory acidosis, the expected change is, I don't know, this formula. For chronic respiratory acidosis, the expected change is that formula. In this case, the observed change is pH is around 0.09. This falls between the expected change, the expected values for acute change and chronic change, respiratory acidosis. Thus, the appropriate conclusion is that this represents an acute and chronic respiratory acidosis, which also agrees with the diagnosis of hypoventilation secondary to obesity. Okay, and it's not, what's that? G. A ventilation perfusion mismatch refers to imbalance in the amount of blood perfused in alveoli where gas exchange can take place. Due to the mismatch, the AA gradient is generally increased. Okay.
You ready?
Next.
Yes.
Mm-hmm.
Next. Lots of pulmonary questions.
Yeah, right?
Yes. A 32-year-old a 32-year-old woman is brought to the emergency department 30 minutes after being involved in head-on motor vehicle collision. She was unrestrained from seat passenger. She is alert. Temperature is 36.8. Pulse is 110 per minute. Respiration is 16 per minute. Blood pressure is 140 by 85 millimeter mercury. Examination shows ecchymosis over the forehead, left side of the chest, and upper abdomen. The pulse is equal and reactive to life. There is no jugular venous distension. Breath sounds are decreased over the left lung base. Heart sounds are normal. Abdominal examination shows epigastric tenderness. X-ray of the chest is shown. Which of the following is the most likely diagnosis? Ready?
Yeah, I guess. Seconds. Yes. So is diaphragmatic rupture. Traumatic diaphragmatic hernia can occur after penetrating injury and bulk or lung trauma, which is caused by sudden increase in intra-abdominal pressure that leads to rupture of the diaphragm. Opening in the diaphragm can lead to the presence of abdominal content within the thorax and present with chest pain, shortness of breath, bowel within the lung feels, bowel sounds. It commonly occurs in the left hemithorax and may be visualized as intestinal lobes or other abdominal organs in the thorax. On X-ray, in this patient checks X-ray, there is gastric bubble visible in the left hemithorax. Where?
Where is the bubble?
I, I, Okay. How the chest X-ray finding can include elevation of the hemi diaphragm,
You found the
abnormal.
bubble?
Nope. I thought it was the diaphragm itself that went up. That's what I thought. Anyway. Nasogastric tube positioning, atelectasis, blunting of normal architecture management is surgical exploration and repair of the ruptured diaphragm. It is not, what was that? I was between hemothorax, result from blood accumulating within pleural space, often from trauma to the pulmonary bronchial intercostal vessels in the setting of rib fractures or penetrating trauma. Present with chest pain, shortness of breath, dullness to percussion. In the diminished breath sound, the affected side, massive hemodynamic stability may occur from blood loss or tension on blood vessels. Non-pulmonary contusion also may occur after blunt or penetrating trauma to the chest. They often underlie the region of trauma to the chest wall and result from damage to the capillary with associated leakage of intravascular and extravascular fluid into the pulmonary interstitium and alveolar spaces. On chest X-ray, pulmonary contusion appears interstitial infiltrate, opaque alveolar opacities. Okay.
Okay, let's take a break, 5 to 10 minutes.
Okay.
Okay, I'm coming.
Okay.
7 days after undergoing splenectomy, 7 days after undergoing splenectomy for refractory bleeding after being kicked by a horse. A 25-year-old woman has a temperature of 39 degrees Celsius in the malaise. She received 8 units of paclitaxel during the first 24 hours after the operation. Her post-operative course had been uncomplicated until today. Her pulse is 110 per minute, blood pressure is 120 by 70. Examination shows well healing surgical incision without erythema and tenderness. Breath sounds are decreased on the left. The abdomen is soft with mild fullness in the left upper quadrant. Her hematocrit is 30%. Leukocyte count is 25,000 with a left shift and the platelet count is 8 lakh. An X-ray chest shows left-sided pleural effusion. Which of the following is the most appropriate next step in the management?
Ready?
Yes.
CT scan. Postoperative complications can include infection, bleeding, wound adhesions, thromboembolic disease. Common cause of postoperative fever are atelectasis, pneumonia, UTI, infections of the surgical site, intrathoracic or intra-abdominal infection related to surgery, thromboembolic disease with DVT or PE can also present with fever, and bacteremia can also cause fever. This patient, the most likely cause of fever is due to intra-abdominal or surgical site causing intra-abdominal or surgical site abscess causing fever. Leukocytosis with leches and abdominal formations in the left upper quadrant at the site of splenectomy. To diagnose an intra-abdominal abscess, CT scan of the abdomen with contrast should be performed. Management involves IV antibiotic and in some cases percutaneous or operative drainage. Next.
Yes. A previously healthy 25-year-old woman comes to the office because of 4-month history of intermittent abdominal cramps. During this period, she has noticed occasional mucus. She has noticed occasional mucus mixed with her stool, but has never noted any bright red blood. She is 168 centimeter tall and weight is 45 kg. BMI is 16 kg per meter square. Vital signs are within normal limit. Abdominal examination shows mild tenderness to palpation of the right lower quadrant. There is no distension guarding rebound. Rectal examination shows normal sphincter tone, a non-inflamed anal fistula, browns, a non-inflamed anal fistula, brown stool, no masses. Test of the stool for occult blood is positive. Which of the following is the most likely diagnosis? Hmm,
Ready?
Yes,
So it's Crohn's. Crohn's, the most of it diagnosis is young patient with low BMI, positive fecal occur blood test,
ulcer.
diarrhea.
Why? Okay. Ulcerative colitis usually have, okay, non-inflamed anal fistula. Okay.
So that positive fecal occur blood test, diarrhea with mucus and the presence of an anal fistula an exam. Crohn's disease characterized by transmissible inflammation of the GI tract, most commonly, most frequently involving the terminal ileum. It can arise anywhere in the GI tract and it's a subclass of IBD. Most patients experience chronic abdominal pain, body diarrhea, weight loss. Exam often demonstrate generalized abdominal tenderness, worse in the right lower quadrant, depending on the severity of extent. May discuss complications such as enterocutaneous fistula, and extraintestinal manifestations such as uveitis. Severe Crohn's can result in intestinal obstruction from structure or inflammation, bowel perforation and abdominal abscess, formation or addition of fistulas. Diagnosis occurs through imaging and biopsy. Lab analysis often show increased ESR and CRP. Fluoroscopic small bowel follow through commonly shows narrowing of the intestinal lumen at the terminal volume, along with other additional sites of stricture and fistulous formation. Treatment depends upon severity and extent of disease, but includes 5-ASA derivatives, topical or oral steroids, biologic agents such as anti-TNF inhibitors. Surgery sometimes required. Next,
Yes. A 16-year-old boy is brought to the emergency department because of 6-month history of intermittent bright red. Because of 6-month history of intermittent bright red rectal bleeding, he has no serious illness, takes no medication, vital signs are within normal limits, cardiopulmonary examination shows no abnormality, digital rectal examination shows blood in the rectal valve, digital rectal examination shows blood in the rectal valve, endoscopy shows scattered 1 to 2 centimeter polyps throughout the 1 to 2 centimeter polyps throughout the colon. Endoscopic polypectomy of the larger polyp is performed. Rec- Results of biopsy of the polyp show dilated cystic mucus filled glands with abundant lamina propria and inflammatory infiltrate. Which of the following is the most likely diagnosis? 16-year-old boy.
I don't even know what's Cowden disease and Canada syndrome. I'm like, I don't even know what they are doing. So, so I'm not even
Uh,
going to try to.
is there any possibility of FAP? Because very early.
I'm,
See,
I'm between familial and juvenile polyposis, but I feel like if they wanted familial, they would have said that somebody in the family has it. So I'm thinking it's juvenile polyposis. Don't
they
quote me on
haven't
that. Don't
they
know.
haven't give the family history,
Yeah. I feel like if they wanted family, I don't know. Juvenile polyposis is just
but they
polyps. I
are
don't know.
like endoscopy shows 1 to 2 centimeter polyps throughout the colon. Familial
Throughout the,
colon.
I don't know. I feel like it's the adenomatous polyposis or juvenile polyposis. Anyway, ready? It's just too
Yes.
much. It's same as the book. It's not on that side. It's juvenile polyposis.
Okay, you are right.
Hmm. Yeah, I feel like familiar, they would have told you like somebody in the family has it.
Okay.
Juvenile polyposis most likely diagnosis in pediatric patient with painless intermittent hematochezia and polyps demonstrating dilated cystic mucous filled glands. JPS, juvenile polyposis, genetic condition with incomplete penetrance that it's inheriting in autosomal dominant fashion and occurs as the result of mutation in the SMAD4 and DMPR1A genes. Patients typically present within the first 2 decades of life with painless rectal bleeding secondary to polyps, although other more severe manifestations include intussusception and Malazotti syndrome. Colonoscopy often discloses numerous polyps, but the histology, histology is characteristic and sets GPS apart from many other polyposis syndrome. Polyps GPS may be of many different types, but the most common are called hematomas. Hematomas polyps are made of various tissues within the GIT, and histologically they have inflamed cells within the lamina propria in addition to mucus-filled dilated glands. Other associated findings include telangiectation of the skin, GI tract, the liver, and the lungs. Iron deficiency anemia may develop in patients with chronic GI bleeding and should be monitored. Screening for colorectal cancer should be performed every 1 to 3 years after diagnosis. And in some cases, patients may require colectomy. It's not Cowden disease. Cowden is genetic syndrome, often although not always associated with mutation in the P10 tumor suppressor gene. Patients present with mucocutaneous findings, including trichi- tricholemomas,
What is
breast
that?
cancer, thyroid, I don't know, endometrial renal cancer, a variety of GI disorders, including colonic, duodenal, and gastric polyps or
All the
colorectal
cancers.
cancer. Tricholemomas. Let me see. Tricholemoma. Benign non-cancer tumors are the root sheet of the follicle. Okay, it's just a bump.
Okay.
Bump somewhere. And it's not uh, chronic, chronic Canada syndrome characterized by alopecia, onychodystrophy, and polyps. Oh my God. The polyps tend to be amatomatous and eosinophils. This patient does not demonstrate failure with alopecia onychodystrophy. What is that mean? Oh my goodness.
Canada, Canada.
Huh. Onychodystrophy. Something with the nails. Abnormality in the
Dystrophy. You are talking that.
onychodystrophy. Yeah.
Dystrophy.
Onychodystrophy. Something with the nails. Okay, so it's Canada is something alopecia, something with the nails and polyps. And it's not familiar adenomatous. Oh, Jesus. Polyposis, autosomal dominant genetic syndrome resulting in APC gene loss of function. Presence of thousands of adenomatous polyps arising after puberty.
This is new
Yeah.
information. This
Okay.
polyp can arise after puberty. Okay. You want to read other options?
No, no, no. That's it. I hope we're never going to see that Canada thing in Cowden because I'm probably not going to remember.
Canada people has no hair, alopecia, and there is nail problem, and there is another thing like polyp, isn't it? Let-
Yeah. In
Okay.
Cowden,
Cowden is like everything, like GI cancer, breast cancer, thyroid cancer.
okay.
Okay.
And I don't know how we would have, I guess how we would have differentiated between familial and juvenile here.
What you have said, like if family history is given, then it is FAB,
Okay.
and another one is like if the polyp appears after puberty, but this is pre-pubertal, but 16 years old boy,
No, that's
it,
after puberty.
yes, so it does not match. So is there anything we can,
No.
very tough, like you guessed it with the
Yeah.
family history and the age, like juvenile.
No,
Okay.
I guess that because I just was, I'm not going to pick the Cowden and I don't know what they are, so I'm
No,
just
no,
not going to pick
Cowden
it.
Crocknight, we have excluded that, but FAB has the probability.
Yeah.
Okay, let's go for next. A 33-year-old man comes to the office as a new patient after he recently moved to the state. He visited his last visit to a physician was 2 years ago. He has a 13-year-old. He has a 13-year history of ulcerative colitis, well controlled with mesalamine. His mother has type 2 diabetes mellitus. His father was diagnosed with colon cancer at the age of the 55. The patient does not smoke cigarettes. He drinks 2 12 ounce beer monthly. Vital signs are within normal limits. Examination shows no abnormality. Which of the following is the most appropriate which of the following is the most appropriate colon cancer screening for this patient?
Ready?
Okay.
Right. So it's colonoscopy now. Colonoscopy now is the most appropriate cancer screening for the patient. Colonoscopy guidelines differ based upon whether the patient has underlying genetic disorder that predisposes them to premature colorectal cancer, such as Lynch syndrome, history of IBD, family history of colorectal cancer. The risk for colon cancer in patients with UC increases with duration, extent, and activity of disease. Patient with extensive colitis is a history of uncontrolled inflammation or a disease uh, duration greater than 10 years are at risk of colon cancer. Those with proctitis, left-sided colitis, and history of well-controlled disease are at lower risk of colon cancer. Regardless, all patients should undergo screening colonoscopy 8 years from the date of their diagnosis, as the risk of colorectal cancer increases dramatically after this time. The subsequent screening is like 1 to 3 year interval and is determined by finding in each colonoscopy. Okay, I guess I'll read this one. Colonoscopy at 45 and 50 are both incorrect. The USPFD recommend routine colonoscopy starting at 50 for normal individuals, and between 45 to 40 to 45 for individuals at higher risk. However, blah, blah, Guidelines have recently been updated and recommend consideration for routine screening colonoscopy starting at 40 for average risk individuals. Okay, so is it 40? Okay, I guess right now it's 40. Okay, next.
Okay. What is virtual colonoscopy?
Virtual colonoscopy, also known as CT colonography, involves placing a rectal tube to distend the colon with gas prior to obtaining CT images of the entire colon. This is reasonable, though not ideal, for patients at average risk of colorectal cancer, but is not used for evaluation of patients with higher risk. CT colonography, so CT of the colon, I guess.
Okay. Next. A 67-year-old man, a 67-year-old man with a 2-year history of gastroesophageal reflux disease comes to the physician for a follow-up examination. Treatment with maximum doses of proton pump inhibitors has not relieved his symptoms. He has hypertension, hypercholesterolemia. His only medication is hydrochlorothiazide. His blood pressure is 135 by 85. Examination shows no abnormality. Esophagogastroduodenoscopy shows grade 3 eosinophils and Barrett esophagus. A biopsy of the specimen shows mild dysplasia. He undergoes Nissen's fundoplication and his symptoms resolve. Which of the following is the most appropriate next step in the management? Hmm,
Ready?
Wait. Okay.
Okay. So it is repeat EGD and biopsy in 6 months. Repeat EGD and biopsy in 6 months is the most appropriate next step. Barrett esophagus refers to intestinal metaplasia of squamous epithelium in the esophagus. Okay. It is usually a consequence of prolonged GERD, which occurs when acidic gastric contents reflux backward to the lower esophagus into the esophagus. The mucosa of the esophagus is comprised of squamous epithelium and does not traditionally encounter such acidic environment. Constant exposure to acidic intraluminal contents induces a change in cell type from squamous epithelium to columnar glandular epithelium found in the intestine as an adaptive response. Metaplasia can eventually lead to dysplasia, which is premalignant. Patients with confirmed Barrett esophagus should be evaluated at regular intervals determined by presence and or grade of dysplasia. This patient who has undergone Nissen fundus, whatever, still requires follow-up EGD in 6 months to assess the presence of dysplasia. If dysplasia is still present, treatment involves ablation of the dysplastic cell via endoscopy.
Next. A 67-year-old woman is admitted to the hospital through the emergency department for evaluation of the rectal bleeding that began 6 hours ago. Results of colonoscopy 2 years ago severely scattered diverticula. On admission, vital signs are within normal limit. Abdomen is non-tender. She has not had any abdominal pain. Digital rectal examination disclosed gross blood hemoglobin 6.8, leukocyte count 8,000, platelet count 2,15,000. Colonoscopy is done, shows a maroon blood and stool throughout the colon. Radio level erythrocyte scan shows activity in the right lower quadrant. Visceral angiography does not demonstrate constra, active extravasation. During the procedure, the patient receives a transfusion of 3 units of packed red cell. Repeat hemoglobin concentration obtained after transfusion is 6.6. Which of the following is the most appropriate next step?
Hmm.
Is it ulcerative colitis?
Think so?
What is your diagnosis?
I do not have a diagnosis here. I just think it's the diverticular bleeding.
Oh, okay. Diverticulitis. So
Not
diverticulitis. Sorry.
not diverticulitis, just like it's that just diverticular, not the infection. I mean, maybe I'm wrong. Don't follow me. So, sure. Yes,
So you should do surgery.
shows activity of the right lower quadrant. Activity in the right lower quadrant. This is the administration
Sure, in the right lower quadrant.
means the right lower quadrant, so definitely not
Uh,
left hemicolectomy. It's not this. Um,
Is it total?
uh, why? I mean,
Because you cannot stop your bleeding. Because you cannot stop the patient's bleeding. Hemoglobin is very low.
why?
And
Okay,
even if you give 3 units of packed red cell, hemoglobin should be corrected. It is getting low.
okay. Yes, yes.
Do you
Go
have
with
another thought?
no, I really don't have. I'm between that and repeat like your label erythrocyte scan, but it doesn't make sense. What you say makes more sense. Yeah,
Let's see. Okay, we are right.
yes, you're right. Endoscopic management has not been successful at achieving hemostasis. Okay. And the patient continues to have high rate of hemorrhage given the hemoglobin concentration did not change with transfusion of red blood cells. Radiolabel erythrocyte has localized the bleed to the right lower quadrant, but angiography has not revealed the exact site. Without a known site, angiography interventions such as arterial embolization cannot be performed. Given the rate of hemorrhage, the next step is surgical management of the bleed is localized to the right lower quadrant. Segmental colectomy is associated with high rates of rebleeding and mortality in the absence of identified lesion. Next step is abdominal colectomy. And it's not repeat the label erythrocyte is unlikely to provide further useful information at this time. It's more sensitive than angiography as it can detect active bleeding at rates, blah, blah. However, it can only localize bleeding to general segments of the bowel. Follow up to follow up to a positive label, but whatever scan is colonoscopy, angiography, or surgery to isolate the lesion and control bleeding. Next.
Okay. A 62-year-old woman has had halitosis. Is it Jenker's diverticulum? Okay, I'm reading. I'm just okay.
Just congestion and necrosis. Okay.
And progressive dysphagia with spontaneous regurgitation of the undigested food over the past 2 years, and she has lost 2.3 kg during this period. There are no lesions in the mouth. Abdominal examination shows no tenderness or masses. Hmm. Test of the stool. Test of the stool for occult blood is negative. Which of the following is the most appropriate next step in the management?
Okay, now you can say it.
Isn't it?
Yes.
Ready?
Mm-hmm. So is barium swallow most appropriate next step in performing barium swallow? Progressive dysphagia requires a prompt diagnostic workup. Dysphagia is caused by structural and anatomic lesion and neuromuscular whatever. Most patients will undergo EGD initially, however, patients with a history of suggesting of a lesion that is at risk of esophageal perforation should be evaluated with barium swallow first. This includes patients with known or suspected laryngeal or esophageal cancer, history of caustic injury or radiotherapy to the esophagus, or clinical features suggested of zenker diverticulum. Laryngoesophageal diverticulum or zenker diverticulum occurs within the hypopharynx, between the whatever muscles. The mechanism of formation includes uncoordinated swallowing mechanism, which results in muscle spasm of the epipharyngeus, leading to portion diverticular of the wall of the hypopharynx and superior esophagus weakens. Symptoms include halitosis, regurgitation of the digested food, progressive dysphagia, barium swallow shows the posterior midline approaching above or at the level of the epipharyngeus. Treatment includes surgical repair or resection, diverticulectomy, as well as dietary modification to include soft or liquid food. Okay, next.
So Jenker's diverticulum is like outpouching of what?
This is the hypopharynx.
Outpouching of the hypopharynx.
Mm-hmm.
And it comes with the dysphagia or regurgitation and like this halitosis.
Mm-hmm.
What is its treatment?
Surgery.
Okay. And can you read the option E?
E.
Yes.
EGD is not recommended as the initial study in patients with clinical features of Zenker diverticular, as blind endoscopy could result in life-threatening esophageal perforation.
Okay. Oh, got it. Okay. A 57-year-old man comes to the physician because of 4-week history of mild epigastric pain and nausea 1 hour after meals. He has had vomiting, heartburn, bitter taste. He has had vomiting, heartburn, bitter taste in his mouth, weight loss or change in the color of the stool. He has no history of serious illness, takes no medication. He drinks coffee with dinner. He doesn't smoke. Examination shows no abnormalities of the stool for occult blood is positive. Which of the following is the most appropriate next step?
GT or do we do CT?
Why we do city? EGD is ideal, isn't it?
It's ideal, but I feel like it's too.
What is your diagnosis?
I don't have a diagnosis here. It's something in the stomach. I'm thinking.
If something in the stomach, CT scan will show you what?
That's true. Okay, let's do EGD, I guess. Yes, it's EGD. Most appropriate next step management is EGD. Mild epigastric pain and nausea after eating is common caused by GERD. However, this patient also has a cord blood in the stool, evidence of gastrointestinal bleed like melena, hematopoiesia, hematemesis, whatever, and splenaro deficiency. If this symptom is an indication of EGD to rule out malignancy. Okay. Unexplained weight loss, anorexia, progressive dysphagia, and first degree relative with cancer are additional red flags. EGD can rule out additional diagnoses such as esophagitis and collect biopsy samples at the time of procedure. Biopsy samples may look for Helicobacter, malignancy, or autoimmune disease. Let me see, why is it not? CT scan may be used for follow-up study if the EGD is inconclusive. However, cross-sectional imaging studies are less sensitive for lesions along the luminous surface. EGD is preferred for initial workup as biopsy acquisition and any indicated therapeutic measure can be performed at the time of the study. Next.
Yes. A 53-year-old woman comes to the emergency department severe lower because of increasingly severe abdominal cramping and malaise. She has 3 year history of ulcerative pancreatitis treated with sulfasalazine. 4 years ago, she had hematochezia, an increase in frequency and volume of the bowel movements and volumes of the bowel movement. Treatment with prednisolone results in no significant improvement. Temperature is 37.6 degrees Celsius, pulse 110 per minute, respiration 24 per minute, blood pressure 110 by 70. Abdominal examination shows moderate distension, diminished bowel sound, diminished bowel sound, diffuse tenderness without rigidity and palpation, supine and erect. X-ray of the abdomen show gas distending the colon. Gas distending the colon. Which of the following is the most likely diagnosis?
I don't know.
What
It's
is
just,
this? What is her?
I don't know. I'm thinking it's the only thing with
Oh, oh,
ulcerative colitis.
oh, oh, oh. She has 3 year history of ulcerative pancreatitis. Now think.
That's the only thing that made the toxic megacolon is the only thing that goes with
Yes.
ulcerative colitis. I mean, but the vitals are normal, kind of normal, I guess. Okay, let's go
Vital,
with that.
even if vital is normal, toxic megacolon cannot happen.
Oh, I thought you had the vitals had. Okay,
Is
let's
there
next.
anything you have found apart from this?
No, I don't. I know.
Okay,
I
let's
mean,
don't think. Don't
don't
overthink.
overthink it. Okay, don't overthink. Here is toxic megacolon. This patient presentation early concerning for toxic megacolon complication of UC, toxic megacolon life-threatening medical emergency caused by extensive inflammation of colon. The classic constellation of symptoms include fever. That's what I was saying. Fever, tachycardia, hypotension, leukocytosis, enlarged or dilated bowel, impaired colonic motility. More generally, UC is a results in inflammation and ulcers of the colonic mucosa. Typically begin in rectum and advances proximally. Symptoms include chronic abdominal pain, weight loss, bloody diarrhea, abdominal bloated tenesmus, extraintestinal manifestation uveitis. In addition, because of chronic inflammation of the colon, patient are at risk for colon cancer. Treatment of UC flares includes supportive care, immunomodulators, biologic steroids. Severe cases, partial or total colectomy may be required. It's not was also carcinoma of the colon with obstruction. It's another potential complication of chronic inflammatory bowel disease, but it's less likely to explain the patient's current presentation. Now, bowel obstruction typically presents with abdominal pain, distension, obstipation, and constipation. Okay. X-rays typically show proximal colonic dilation with a transition point at the site of obstruction. And it's not dysplasia of the colon with hemorrhage, also called angiodysplasia. Dysplasia of the colon with, okay. It's a common cause of GI bleeding and could explain the patient hematochezia. However, the patient's other system has one explain. Enterocolonic fistula is uncommon in patients with UC. Fistula is for Crohn's. Okay. Okay. Got it.
Next. A 72-year-old man who is in the hospital has had abdominal cramp and bright red rectal bleeding and a bright red rectal bleeding for the past 6 hours. During this period, she has passed three bloody moderately sized. She has passed three bloody moderately sized stool. 2 days ago, he underwent surgical resection and infrarenal abdominal aortic aneurysm. He had a hemorrhage during dissection of the aneurysm and has hypotension for the first 20 minutes of the operation. He received 6 units of packed red blood cells. His initial postoperative course was uncomplicated. He was extubated within 24 hours. Current medications are IV cefazolin and subcutaneous heparin. His current temperature is 38.2 pounds, 100 per minute, blood pressure 124/80. Abdominal examination shows mild distension. Abdominal examination shows mild distension and moderate left lower quadrant tenderness. Which of the following is the most likely diagnosis? Ready?
How you found it so fast?
I thought it is in the left lower quadrant.
Oh, so because so oh okay. That's lower quadrant you said okay. Mm. So you think it's diverticulosis?
It is not pseudomembranous colitis, isn't it?
I know. We yeah for sure no.
And angiodysplasia to happen, we need cardiac complex. Like,
This is
eh,
sickle, so it doesn't even make sense.
sorry,
Sickles.
yes, it does not make sense. And ischemic colitis
I think
can
it's ischemic.
happen, can happen, but she already underwent. Sorry, he already underwent surgical resection of triple A. So the risk factor of a cardiac event or hypertensive event have already passed. And the last thing remains like diverticulosis. Maybe the common thing like left lower quadrant pain, first differential comes in my mind is diverticulosis.
Yeah, I don't know. I feel like it's ischemic colitis because of the hypertension event that he had.
Yes, ischemic colitis can happen. It is an but his blood pressure is normal.
Yeah, his blood pressure is normal. Okay, let's see.
Let's
Yeah,
see.
it's
He,
ischemic colitis
okay.
because he had the hypertension for like 20 minutes. They make sure they specify that he had hypertension for a long amount of time. Okay. Ischemic colitis refers to insufficient blood flow to an area of the intestine and should be suspected in a patient with abdominal pain and hematochezia. Abdominal pain. Yeah. It can be, yeah, because diverticulitis, there is not really pain. It can be caused by an occlusion of the mesenteric vasculature, such as thromboembolism or dissection, or from hypotension or limited blood flow causing a watershed infection. Aortic surgery is a known risk factor for ischemic colitis, also often because of dislodgement of the endovascular plaques with subsequent embolization, or because of hypertension. Risk factors for acute ischemic colitis: old age, coronary artery disease, hypercoagulability, peripheral arterial disease, or recent endovascular surgery. Typical symptoms of patient with acute ischemic colitis: crampy abdominal pain, tenderness over the affected bowel, hematochezia. Ischemic colitis can be complicated by necrosis, viscous perforation, or ileus. Treatment involves supportive care, anticoagulation, antibiotics, antibiotic surgery in case of bowel infection or necrosis or perforation. It's not arterienteric fistula, abnormal communication between the aorta and GI lumen, commonly caused by compression or inflammation of the aorta or bowel in proximity to each other, often in the setting of abdominal aortic aneurysm. A patient may present with GI bleeding, which may be mild or may lead to rapid exsanguination. This patient history of recent surgery complicated by and it's not what we're using diverticulosis, characterized by circular protrusion of the colonic wall and is the most common cause of painless hematochezia. Risk factors for development of diverticulitis include abnormal colonic motility, high dietary intake of red meat and low fiber, physical inactivity, obesity. This patient abdominal cramps and tenderness are not suggestive of diverticulosis. Got
Okay.
it?
Pullosis would be non-painful, like non-tender.
Non-tender hematochezia.
Okay.
And
Painless.
usually it will be constipation or a fat person or whatever.
Eating red meat.
Yeah.
Okay.
Okay, one okay. Quick break,
Yes.
5 minutes.
Obviously, yes.
Okay. Okay.
Okay. Next.
Let's see if we can finish surgery. I'm tired of surgery. I don't like this thing. I'm done. I don't know. I'm just of all the CMS we've been doing, I feel like I'm doing the worst in surgery.
True.
Yeah, I don't know. I don't get it.
Okay.
Okay.
Let's do 5 questions first. Then think. Okay. A 77-year-old woman is brought to the emergency department because of abdominal distension, obstipation for 2 days. She has no history of abdominal operation. She takes 2 milligram of diazepam 3 times daily. Test of the stool or occult blood is negative. X-ray of the abdomen is shown. Which of the following is the most likely diagnosis? 2 milligram 3 times daily. Intussusception. Loss. It is not ischemic coolitis, isn't it? There is no cardiac issue, no
Um,
atrial fibrillation, no
no.
CABG. Mm, not diabetic. Side.
Hmm.
What have you thought?
I think it's the very big, the, what do you call it? Coffee bean thing that we,
Volvulus.
that we never see. Because he
Coffee
says,
bean sign.
yeah, because it says obstipation. Obstipation means no ileocecal intussusception. I feel like will be blood. Diverticulitis, there will be some vital
Intersusception
signs.
happens in the kids. Is the older
Yeah,
people has the chance of having intersusception? I don't know truth.
but it will show blood. They will have hematochezia either way. Carcinoma of the colon and diverticulitis, they don't give enough information because diverticulitis, they should give vital signs, and they didn't give any vital signs. In carcinoma, they should give the losing weight and all these things, and then all this. I'm thinking it's just volvulus. I don't know what will be causing the volvulus. I'm guessing the diazepam, but I'm not sure. But yeah.
Mm,
Ready?
yes.
Yeah, it's volvulus. I guess the coffee bean will be somewhere there. And if you never see it, you will never see it. It's just like whatever. Sigmoid volvulus, uncommon cause of bowel obstruction, uncommon. Okay, and presents with acute onset abdominal pain and distension, constipation, vomiting. Patients are typically old. If untreated, volvulus may lead to bowel necrosis, perforations, which in turn may cause sepsis and septic shock. Sigmoid volvulus occurs when sigmoid colon rotates around its mesentery, resulting in intestinal closed loop luminal obstruction and vascular congestion. X-ray typically demonstrates a dilated air-filled sigmoid colon, while CT scan may demonstrate wear of sigmoid colon around this mesentery. Patients without evidence of sepsis or bowel necrosis may be treated with flexible sigmoidoscopy, which reduces the affected segmental bowel back to normal position. Recurrent volvulus may require colopexy. I don't know what colopexy means. Patients with evidence of sepsis or burn may require surgery. You want me to read another one?
No.
Okay. Yes.
Yes. A 37-year-old woman comes to the physician because of 6-month history of moderate rectal pain, rectal itching, and bleeding with bowel movements. She is otherwise healthy, takes no medication. On digital rectal examination, the rectal issue is tender and inflamed. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the diagnosis?
Ready?
Is it Fisher?
Fisher. Is it Fisher? Is it Fisher? Maybe, yeah. It's a possibility, yeah.
Okay,
Yeah. It's anoscopy. It's a hemorrhoid.
okay, close.
Hemorrhoids occur because of enlargement of this and distal displacement of canal cushions. which are normal prominences of the anal mucosa composed of smooth muscle, vascular, and connective tissue, and play an important role in maintaining continence. Hemorrhoids may primarily involve tissue derived from the internal superior hemorrhoidal plexus or the external and inferior hemorrhoidal plexus. Symptoms include pain with defecation, incontinence, hematophagia, and itching. Hemorrhoids may also undergo acute thrombosis and cause acute or severe pain. The diagnosis is clinical and they may be established with rectal exam, which can be facilitated via anoscopy. Treatment is mainly supportive and includes high fiber diet, sea salts, and oral NSAIDs. Band ligation, sclerotherapy, and surgical excision may be used for severe hemorrhoid or those that fail to improve with conservative management. Okay.
Okay, next. A 42-year-old woman comes to the emergency department because of increasingly severe abdominal pain for the last 4 hours, and the temperature is 102 and shaking chills for the last 2 hours. The pain began 1 hour after eating dinner. During the past 2 weeks, she has 30 minutes episodes of epigastric and right upper quadrant and abdominal pain after eating. Treatment with antacid, some treatment with antacid sometimes relieves pain. She is now lying still on the examination table. Her temperature is 39, 103.1 degree Fahrenheit, pulse is 110 per minute, respiration 22 per minute, blood pressure 90/60. Examination shows scleral teras and jaundice. Abdominal examination shows right upper quadrant tenderness to percussion and involuntary guarding. Vowel sounds are normal. Urine analysis is positive for bile. Which of the following is the most likely diagnosis?
Cholangitis and cholecystitis. I guess it's cholangitis. Uh,
Cholangitis has a triad, isn't it?
what was that? It was the I forgot to forget.
There was a triad called Charcot's triad, something like
Mm,
that. Fever, jaundice, right upper quadrant pain.
jaundice. Okay. And cholecystitis was the track. Oh, no, they expired for that one. Okay. Ready?
Yes, I'm thinking.
Yeah. Cholangitis.
Okay.
Polylithiasis refers to presence of gallstone in the gallbladder. Polylithiasis. Polydopolithiasis refers to presence of gallstone within the biliary tree. I always get confused with this. Polylithiasis, gallstone in gallbladder. Polydopolithiasis, gallstone in biliary. Gallstone can result in varying degree of obstruction, which dictates the whatever. Polylithiasis, which is gallstone in the gallbladder, can result of colicky, right upper quadrant pain or epigastric pain, biliary colic, nausea, vomiting with obstructive polydopolithiasis, increased direct bilirubin, and alcohols may present on lab assay. along with persistent not colicky discomfort and exam. Hyperbilirubinemia can lead to scleral icterus and jaundice depending on the location of the bile duct stone. Cholelocholithiasis can result in acute pancreatitis, which manifests with epigastric blah blah blah, amylase lipase are high. Acute cholangitis occurs secondary to acute bacterial infection of the biliary, typically in the setting of biliary instrumentation. Cholelocholithiasis as a precursor. Cholangitis describes a bacterial infection or inflammation of the biliary tree and commonly presents with fever, right of recurrent pain, jaundice, along with possible shock and mental status, Raynaud pentat. Charcot triad is fever, right of recurrent pain, and jaundice. Raynaud pentat is plus shock and mental status. Treatment includes through fluid resuscitation, antibiotic, procedural intervention to clear any obstructing and permit drainage. It's not cholecystitis generally results from obstruction of the cystic duct by gallstone, with resultant bacterial infection of the gallbladder, and presents with hydrochloride pain, nausea, vomiting. Since it does not cause obstruction of the common bile duct, it would not cause jaundice. Oh, that's the key, the jaundice. Okay, next.
Okay. A 57-year-old woman comes to the emergency department because of 1 year history of increasingly severe left-sided chest pain that is worse when she inhales. 6 hours ago, she underwent upper GI endoscopy because of 1 month history of progressive dysphagia. Results showed a benign appearing stricture of the distal esophagus that was balloon dilated. Her only medication is esomeprazole for gastroesophageal reflux disease. She does not smoke cigarettes or drink alcohol. She appears anxious. Her temperature is 37.9 degrees Celsius. Pulse is 110 per minute. Respiration 20 per minute. Blood pressure 110 by 65. Examination shows splinting of the left chest during inspiration. Cardiac examination shows regular tachycardia. Abdominal examination shows no abdomen. Chest X-ray shows a small left pleural effusion. Which of the following is the most appropriate next step in the diagnosis?
Hmm. Hmm. Do we do thoracocentesis or do we do the water soluble?
As it has uh, done after endoscopic procedure. 1 month history.
It's something that has to do with the endoscopy that uh,
Yes, endoscopy has causing some sort of problem.
open
But this endoscopy, 1 month history after that endoscopy.
1 point with 6 hours. No, it wasn't one. Oh, no, it wasn't 1 month. 6 hours ago.
Oh,
Um,
okay.
so the endoscopy goes like an opening that goes into the pleural. So, and she has fever. So, do we do thoracocentesis to see if the pleural effusion has something, or do we do water solid? I guess I'll do that.
Thoracocentesis will. Oh, I think that water soluble contrast, isn't it?
You think water soluble contrast?
Thoracocentesis will uh, will if there is pleural effusion, if there is infection like due to the cause of the, if you think about the cause of the pleural effusion, it does not fit with the endoscopy, isn't it?
What do you mean? No, I don't understand what you're saying.
Okay, let's see what is the answer.
Okay, I'll pick between. I know it's A or D. Okay, I'll pick D. Fine.
I think it's A.
It's A.
Okay, you
Operandus.
take.
It's A. It's A. Water
Okay,
soluble contrast. Operendoscopy is generally safe, though in complications can include bleeding, aspiration, perforation, depending on the purpose of the endoscopy. Specific complications such as pancreatitis following ERCP can occur. In the case of this patient, the endoscopy was performed and dilated an esophageal was performed and dilated an esophageal structure to promote passage of blood. Stretching of muscle, smooth muscle, structure and connective tissue, especially if chronic inflammation has resulted in compromise of the stromal strength of the esophageal, can lead to perforation. Perforated esophagus is diagnosed on water-soluble contrast esophageal tube, and esophageal perforation permits translocation of GI contents such as food, stomach acid, and bacteria into the mediastinum, which can lead to mediastinitis. Mediastinitis can present with chest pain and generally toxic appearance like fever, tachycardia, tachypnea, and euphoresis. Management esophageal perforation is antibiotic and surgery. It's not D. What is D? Oh, thoracocentesis may be necessary if translocated gastric content develop into empyema. However, such a complication will not be evident for several days. It may be avoided together with the use of antibiotics. Okay. Next.
okay.
Okay.
A 25-year-old man has post-operative pain 6 hours after a mesh repair of an inguinal hernia under local anesthesia. Which of the following is the most appropriate analgesic pharmacotherapy for incisional pain?
Hmm. Hmm. Very.
Hmm, okay, wait.
Oh,
And, okay,
okay. So it is oxycodone and acetaminophen. Incisional pain after abdominal surgery can be moderate to severe and typically lasts from days to weeks. Oral administration of non-opiate medications may be helpful to maintain for pain control. The patient may require opioid analgesic to control severe pain. Typically, the approach to adequately control pain is multimodal. While opioid medication can offer strong analgesia, opiates are CNS depressant and can lead to dependent addiction and death. Opioid intoxication causes sedation, bradycardia, hypotension, blah, blah, blah. Opiates are commonly used for analgesia and act on receptors within the GI tract, the gut, causing constipation. Adjunctive pain medications such as acetaminophen and NSAID gabapentin can help reduce the use of opioids and reduce the risk of side effects and dependence. Short-term therapy following surgery with opioid compounds is indicated. Though care should be taken to avoid prolonged use due to the risk of side effects and dependence. It's not oral morphine. Morphine sulfate and other opioid medication can be helpful in treating severe acute pain. However, multimodal pain regimens such as those containing acetaminophen and non-opioid medication are safer and reduce the risk of opioid tolerance. It's not infiltration of the wound by bupivacaine will be helpful for immediate pain, but only lasts for several hours, and it will not be adequate to help treat postoperative pain that can last for days. Okay,
Okay.
next.
It, 5-week-old A 5-week-old boy is brought to the physician because of 4-week history of progressive jaundice. He was born at term following an uncomplicated pregnancy and delivery. His mother says that his stools are white. He is at 50 percentile for height and weight. Temperature is 37.4 degrees Celsius. Examination shows a moderate jaundice. The liver edge is palpated 4 centimeters below the right costal margin and is slightly tender. Serum study shows bilirubin 12.4, direct bilirubin is 8.3, alphos is 551, ALT 51, ALT 47, alpha 1 antitrypsin is normal. A torch assay is negative, and ultrasonography of the abdomen does not show a gallbladder. A technetium-99 particulate scan shows prompt uptake throughout the liver. No gallbladder, no tracer appears in the bowel. Which of the following is the most likely mechanism of the jaundice?
Ready?
Wait, yes,
So is impaired bile flow through the ducts. In congenital biliary atresia, the common bile duct is occluded in small or absent, and bile is unable to pass in the duodenum. This precludes the use of bile in the digestion of dietary fats and causes fat malabsorption. In contrast, the benign causes of in contrast to benign causes of neonatal jaundice, biliary atresia presents with progressive worsening jaundice, conjugated hyperbilirubin, pale stools, dark urine, poor weight, and untreated cases cirrhosis, coagulopathy, and portal hypertension. Classically, benign etiologies of neonatal jaundice will improve by the second to third week of life, whereas biliary atresia will persist and will be worse by first 8 weeks of life. Diagnosis consists of history and physical exam, liver function testing, high scan and cholangiography, with definitive diagnosis occurring during respiratory surgery, visualizing athletic bile ducts. Treatment is through hepatoenterostomy, the Kasai procedure, hepatoenterostomy, which restores biliary flow, reduces jaundice, and helps salvage the liver. Liver transplant may be required if the procedure is unsuccessful. Okay, next.
yes. 24 hours after undergoing splenectomy for trauma sustained in a motor vehicle collision. A previously healthy 25-year-old woman has urinary catheter is in place and her urine output has been 20 ml per hour during the past 3 hours. Intraoperative complication included a 30-minute period of hypotension, 30-minute period of hypotension, and the total blood loss is 2.5 liter, requiring 4 units of packed red cell. Currently her temperature is 38, pulse is 100 per minute, respiration 14 per minute, blood pressure 120 by 80 millimeter mercury. The lungs are clear to auscultation, breath sounds are heard bilaterally. Abdominal examination shows no distension. Abdominal examination shows no distension. Um, bowel sounds are absent. Lab studies show hematocrit 28%. Serum urea nitrogen is 30. Serum creatinine is 2.5. Our electrolyte concentration are within reference ages. Central venous pressure is 8. Which of the following is the most appropriate next step to confirm that the oligo?
No? Ready?
Yes.
So it's measurement of urine sodium and creatinine concentrations. AKI is defined as a acute increase in creatinine by greater than or equal than zero point 0.3 mgdl or 1.5 times above the average, occasionally with oliguria and or anemia. AKI can be perirenal because of dehydration or vascular perfusion states such as congestive heart failure or ATN, or postrenal because of obstruction. A common cause of ATN, which can be caused by ischemia in the setting of prolonged hypoperfusion of toxins. A way to distinguish between causes of AKI is by measuring the fractional excretion of sodium. The fractional excretion of solute measures the percentage of the original filter amount that is present in the excreted urine. The calculations are made using the plasma and urine concentrations of sodium and creatinine. Perirenal intrinsic kidney injury can be distinguished by the fractional excretion of sodium, which is less than 1% in prerenal and more than 2% in intrinsic kidney injury. In acute tubular necrosis, lab evaluation will show a blood urea nitrogen to creatinine uh, ratio less than 20, a fractional excretion of sodium less greater than 2%, and muddy brown cast urinalysis. It's not measurement of plasma-free hemoglobin concentration, the amount of hemoglobin that is not enclosed in red blood cells may help diagnose hemolytic anemia and explain renal tubular injury from free hemoglobin. Measurement of free hemoglobin concentration would not be informative in delineating cause of acute kidney injury in the setting of blood transfusion unless hemolysis or incompatibility were expected. Okay, next.
Okay. A 32-year-old man is brought to the emergency department after sustaining extensive injury in a motor vehicle collision. His pulse is 100 per minute, respiration 15 per minute, blood pressure 120 by 70. Cardiopulmonary examination shows no abnormality. The lower abdomen is tender. There is blood at the urethral meatus. On rectal examination, the prostate is not palpable. There is no blood. Which of the following is the most appropriate next step in evaluation of the urinary tract?
Ready?
Wait. Okay.
Blood in the urethral meatus is like automatic retrograde or retrograde. Patient with pelvic injury and blood in urethral meatus, suspicion for urethral injury, urethral injury characterized by difficulty voiding blood in the urethra, perineal ecchymosis. Throughout the injuries can cause trauma anterior urethral wall. Pelvic fractures may injure the posterior urethra. Urethral injury evaluated by retrograde urethroplasty, which involves injection of contrast into the urethra to evaluate for the stabilization of content. Depending on the location or severity of the urethra, injury patients may require surgical repair or the placement of urethral catheter to promote healing. Okay, next.
Okay, a 32-year-old woman comes to the physician because of bloody discharge from the right nipple for 2 weeks. There are no breast masses or axillary or supraclavicular adenopathy. Mammography shows normal findings. The nipple and the areola are normal. Which of the following is the most likely diagnosis?
Ready?
1 second. Is it intraductal papilloma?
Yes, insert
Okay.
keywords bloody nipple, no mass, reductive papilloma.
Okay.
Most common cause unilateral bloody nipple discharge, adulteral papillomas may be associated with focal ductal carcinoma. Oh. However, intraductal papilloma itself is benign. Oh, okay. Nipple discharge may be caused by lactation, physiologic mechanism, galactorrhea, or pathologic lesions such as breast cancer infection. Evaluation includes careful history and physical exam with particular attention paid to whether the discharge is unilateral or bilateral, is from a single or multiple ducts, and whether it is associated with skin changes, lumps. Lactation and physiologic discharge are more commonly bilateral for multiple ducts, whereas pathologic lesions more commonly unilateral. Further diagnostic evaluation of pathologic discharge in this patient involves ultrasound or mammogram, depending on the patient age, and biopsy if normality is detected. Next.
Okay. An otherwise healthy 40-year-old woman, Gravida to Parado, comes to the office 2 weeks after she noticed a tender mass on her left breast while showering. Menarche was at uh, Menarche was at age of 12 years. The patient has the patient had her first child at the age of 28 years and underwent tubal ligation of her second after the birth of her second child 8 years ago. The patient's maternal aunt was diagnosed with breast cancer at the age of 75 years. Examination of the patient shows no lymphadenopathy. The breasts appear normal and symmetric. Palpation of the breast shows normal breast tissue bilaterally. There is 2 centimeter firm mass on the upper outer quadrant of the left breast with no skin or chest wall attachment. Mammography confirms solitary mass and a well-defined Mammography confirms solitary mass and a well-defined mass in the same location. Ultrasonography of the breast shows that the mass is fluid-filled, compressible, with posterior shadowing. Which of the following is the most appropriate next evaluation?
Ready?
Okay,
There's needle aspiration. Breast masses are common in women. Evaluation of a new breast mass includes history and physical. Benign masses commonly small, well circumscribed, mobile, whereas malignant, large, fully defined, adherent to tissue and associated with skin or nipple discharge. Further, diagnostic of breast mass depends on age and concern for malignancy. Younger than 30, ultrasound. Older than 30, mammogram. Occasionally, abnormalities on one imaging modality are confirmed with the alternative modality. In this case, the patient must visualize on mammogram confirm the breast ultrasound, confirmed with breast ultrasound, which discloses a cystic appearing lesion. Cystic lesions should be carefully observed and undergo needle aspiration for cytologic evaluation. Also, a simple cyst that completely collapses after aspiration requires no further management. Excisional biopsy, maybe I haven't read the other ones, and involves surgical excision of the entire breast mass, whereas incisional biopsy removes only a portion of the mass. This procedure may be utilized for solid lesions that have imaging findings of clinical concerns for malignancy. These patients have cystic appearing lesion most suitable for needle aspiration. Less invasive options are biopsy that major. Mammography localized needle biopsy may be useful in evaluating a solid lesion that is not evident on physical exam. Hmm. Mammography localized allows the biopsy to include more tissue more reliable from the area of imaging abnormality. This patient lesion is still palpable on physical exam and easily evident on ultrasound, making finding. Yeah. MRI is rarely utilized in the evaluation of breast lesions, so it's commonly used in screening modality for patients at high risk for invasive breast cancer, such as those with BRCA1, BRCA2, given its sensitivity for detecting breast cancer. It may also be used preoperatively to evaluate the extent of disease in women with newly diagnosed breast cancer or to evaluate for occult breast malignancy in patients with axillary lymphadenopathy. This patient thing is visible. Okay, that's it. We can stop here.
Okay. Yes.
Okay, I will see you tomorrow.